Top Med Talk.
Welcome to this, the final instalment of our series entitled Perioperative Pain Management. Here we have a fascinating panel discussion chaired by John Whittle, a clinical academic working in perioperative translational medicine at UCL and honorary consultant in perioperative medicine, anesthesia and critical care at University College Hospitals, London. The speakers on the panel are Tim Miller, Professor of Anesthesiology at Duke University Medical Center, Fauzia Hasnie, Consultant Lead at the Opioid Multidisciplinary Pain Management Clinic, Joint Lead of the Combined Sickle-Opioid Virtual Multidisciplinary Clinic at Guy's and St Thomas's NHS Foundation Trust, and last but not least, Esteban Salas Rezola, Specialist in Anesthesiology, Resuscitation and Pain Therapy at Hospital General Alicante. Each of the panel members have presented their case to you in previous podcasts here on Top Med Talk. All of those podcasts are linked to in the show notes. These presentations and this discussion were originally hosted by Evidence-Based Perioperative Medicine, or EBPOM, at their World Conference in London last year. Don't forget you can hear these discussions before anyone else by simply getting yourself onto the EBPOM website, ebpom.org, and getting some tickets for this year's conference.
So it's been quite a wide-ranging session covering a bunch of different topics. I might jump in with my first question, if you don't mind. So we have been looking at pain management in our perioperative pathway recently, and we have our rehabilitation service. And we noticed a lot of patients coming through. We're seeing these patients 6 weeks, 8 weeks before surgery. And there's a lot of patients, as you guys have clearly described, on opiates with chronic pain. And we know that patients with chronic pain do badly across a multitude of domains in the perioperative period. But we'll be scratching our heads what we can actually do about it. And Fauzia, you were saying, well, look, it can take quite a while, can't it, to de-escalate? And this is time that we don't often have in our preoperative workup period. So I guess I'd be interested in your ideas as to what we can do to mitigate the effects of patients on high doses of opiates pre-op, maybe as part of a pre-optimization pathway. For you, Fauzia.
It's hugely complicated, isn't it? It depends so much on the patient, the surgery they're having, their beliefs about opioids, about medication. I don't think there's a straightforward, easy answer for that. I mean, you're quite right, it does take months, but in your clinic you have just a few weeks, don't you? So what can you do in a few weeks? Well, I suppose the truth is whatever you can do to reduce will be better for them in the longer term, because then they'll be more responsive to any opioids that they do get in hospital. I suppose it's about looking at other non-opioid strategies. I mean, so what we do in outpatients is very different to, say, for example, inpatient detox. That's the completely different scenario. So with that, what you're doing be actually purposely inducing withdrawal, and you're getting them off the opioids quickly, and then you're replacing that with substitution therapy like buprenorphine. But I wouldn't advise doing that with someone who's on a high dose, a very high dose, relatively.
Well, I mean, I'll tell you, I think essentially that's our experience. Is there anyone else running preoperative clinics? I mean,
when we had a pre-op opioid reduction clinic that we started at Duke, it was there when you were there, and we've largely pivoted that we're not sure the preoperative space is the place. We still see patients in the clinic, but it's more to get them into the perioperative pain service, come up with a plan for their intraoperative management, which will involve regional, of course, wherever possible, adjuncts such as ketamine to try and keep them on their baseline opioids, but minimize additional opioids, and then continue follow-up afterwards, which is when you'll try the opioid reduction, which, as you say, may take 12 months. But in that 3 to 4 weeks, or it was less sometimes preoperatively, realistically, is it in the patients or anyone interested at that time to be trying to reduce opioids? And I think we've come to the conclusion that generally, no. But it's getting them into the system and educating them and coming up with a plan for post-op opioid reduction within the system.
Could I make a point? I think if you can reduce a little bit of their opioids, actually, because we know that opioids do suppress immune function. So if they're on high doses, they're going to be more at risk of infection perioperatively. So I think if you can reduce them, even if it is a little bit, it's probably still worthwhile to do that. But I get your point that you've only got 3 or 4 weeks. There's not much that you can really achieve in that, because it can take that long to get a change in your prescription, I suppose. But
Right. And I guess that's where we've got to so far, is this leaning into education as being probably the key component, and expectation management, and then kind of leading into some of the stuff we've talked about, pathway management. Okay, well, I'll start with a controversial Slido comment or question at the top, because it has been touched upon twice. So it says, using a drug cocktail with no proven safety in the name of opioid-free anesthesia could cause more serious harm than side effects caused by opioid. So I guess that I'm going to reformulate that as a question. So there has been some data presented today about perioperative pathways which are opioid reduced or opioid sparing or opioid-free, but it is a common question I come up against in my clinical practice as well. How do you know if you're giving whatever cocktail, my cocktail, I call it, I can't believe it's not Remy.
I think the cocktail, my cocktail.
But it's your cocktail. So let's go to Esteban.
Yeah, I'll say
Yeah.
there are very low doses of all these drugs and all calculated. I haven't talked enough about them. It's a protocol developed by Dr. Muller. I've been working with him in Belgium in a obese patient bariatric surgery hospital. So that's why I talk about less opioid, because I think if you use too much these drugs, you're going to have the side effects of these drugs. So just something a little bit more balanced, little bit of opioids, little bit of all these drugs, because I've been a lot of years using them, and to make a total opioid-free anesthesia, you have to overdose sometimes of all these drugs. So it's not worth at the end. So that's what I say, that at the end, after 10 years making really extreme offers, it doesn't make sense. That's my own experience. So I agree with this. But I say this cocktail has a very low doses of these drugs. So probably we use lidocaine with toxic drugs with another blocks or whatever. But with this intravenous cocktail, it's really difficult to get overdose or side effects to the patient. I put some fentanyl now, so something balanced. Sorry. So what's the point? Measure it. So that's the only way to not overdose a patient, although with these drugs. So you need a monitor.
So multi-monitoring. Okay, we'll get on to that again in a second, because I'm very interested in that. Never used it, heard peripherally. Tim, from your point of view, I remember at Duke, we were using some opioid-reduced strategies, particularly colorectal surgery, but you alluded to some of the side effects from those.
I mean, I completely agree with this. I mean, as I presented in my presentation, this is real. So we have to be aware we're not switching, the devil in the dark blue sea. But that being said, can you do opioid-free anesthesia? Of course. I mean, you don't need opioids to put an endotracheal tube in. You can give some esmolol or give a perfectly balanced anesthetic. I mean, I've had patients coming for a lap chole who, get severe PONV and say they get, whenever they get opioids, they feel terrible, and ask if I can minimize or eliminate opioids. And I've done an opioid-free technique, and they've been looked great in PACU, and they've been very happy. And it involves a combination of, blocks and multimodal. But I do think we've got to be careful what we're doing, because it's not as if a lot of these drugs aren't free of side effects, particularly when we do polypharmacy. But it is absolutely feasible and can be very beneficial in the right patients, particularly if you can add in regional anesthesia as well.
And we heard a few, because again, there may be different use cases of different operations, right? Yeah. So we've just heard about the effects of opioids on immunity. Lidocaine, I talked about a couple of days ago in the context of onco anesthesia. And I guess one of the questions is about cocktails and unpicking the individual effects, which we're not there yet, are we? And what is your outcome? Because we've talked two different contexts. We've got opioid crisis, deprescribing, trying to deal with the wider epidemiological effects. We've talked the impact of chronic pain on outcomes, and then we can talk about individual side effects. I wonder, in the audience, just show of hands, how many in this audience routinely practice opioid-free anesthesia? A small minority, but there is a minority. Opioid sparing as part of routine care. Okay. Yeah, so again, about 50%, which is interesting because I was going to bring me on to another question, Tim, because actually Duke has got two faces to it, hasn't it? You have colleague Dr. Quaresh, who uses methadone as a perioperative opioid on the other side and has published a whole bunch of papers. Do you want to briefly talk to that if you feel?
Yeah, he's a big advocate of methadone, and he tries to put methadone in the frame of an opioid-sparing technique. I mean, methadone is an old drug, but it's a drug that has a long duration of action. So if you wanted to, I mean, at least listening to his presentation, if you wanted to pick a drug that you can give a dose that's going to give you a baseline that's going to last for 24, 48 hours, so you're not getting, spikes of giving boluses of short-acting drugs such as fentanyl in PACU. If you're going to give methadone as part of your multimodal technique and give it in pre-op, I mean, the way he presents it, it makes some sense. And particularly if you're talking about, spine surgery, other major surgery. So it's got a good evidence base. And to say a prolonged duration of action, opioids, makes pharmacologic sense. So that's why he prescribes that. And as part of his armamentarium, we've recently done a large study looking at methadone use, which he's just finishing, is going to be publishing soon, in more moderate surgery. So we will get the results of that. I think it was nearly 1,000 patients. So we'll see. But yeah, we have different people who have different interests.
All right, fair enough. Let's go out to Slido. So now the top-rated Slido question is, should anaesthetists be responsible for the prescription of discharge analgesia, particularly if it includes opioids? Does anyone have that arrangement, and has it helped reduce the frequency and quantity of opioids prescribed at discharge? It's an interesting question.
In the US, we don't. I think that we probably should. We do the intraoperative, perioperative opioid management, and then in our system, it's often turned over to the surgical team to do the post-discharge management. And as I've already alluded to, I think far too much opioids is being prescribed when people get discharged still. I mean, I've had the experience of 2 family members who've had surgery this year, and both of them I've been turning down, saying we don't want any oxycodone when we get discharged for this minor surgery, but it's been prescribed, whereas, non-steroidals and acetaminophen were perfectly adequate to control pain. And in fact, the PACU nurses wanted to give an oxycodone before you get in the car, even though the pain score was 3 or 4. So it's still a massive issue.
I'm going to ask another Slido question. A question here that says, in the opioid deprescribing in patients with ongoing pain, have you found any role for transition to methadone or buprenorphine rather than dose tapering without an aim to cease completely? Both of which have been found advantageous by the question asker. Before, did you want to start?
So, in our experience, I mean, we do rotate patients as they get closer to zero. We do sometimes rotate them to a buprenorphine patch and then aim to then sort of slowly wean that off. And of course, with our addiction psychiatry colleagues, they seem to prefer buprenorphine over methadone. We've had some really tricky patients, one particular one who was on, I think, about 500 mics of fentanyl via patch, and we had a discussion with them about transitioning her onto methadone, and they did not advise that. I don't know fully exactly why that is, but I think their view is that methadone is fraught with problems and you can precipitate all sorts of crises, and you don't actually know what the dose is going to be. It's not a straightforward calculation.
Got it. So let's go on to a null question. So actually, I just wanted to start on this topic. It is of interest to me. I think back sort of 10, 15 years ago, my doctoral thesis was on autonomic dysfunction in the perioperative period. And this is an autonomic monitor, isn't it? Underlying it, you said heart rate variability. Am I interpreting how it works here? True. Heart rate variability, blood pressure variability, and so on. So I guess my observation, which is going to lead into a question, is in our studies, we found that 30 to 50% of patients have autonomic dysfunction leading up to surgery in our general surgical population. So how does that impact the way this monitor, which relies entirely on autonomic responses to external stimuli, how does it impact its ability to discriminate pain?
I give you another question.
Mhm.
What happened with beta blockers? How many people with beta block? How many beta block people we have? At least one each day.
Yeah.
So it's the same question. So, and what happens with a person that cannot change his or her head frequency?
So I would comment on that. So beta blocker
Okay,
have
with that-
analgesic effect.
With that sympathetic block,
yeah.
it's useful and you can use it. Okay, always under general anesthesia. Always under general anesthesia. But because these 4 variables, the combination of them, makes hundreds, tons, millions of different decisions. So if you look at the publications, they start at 2010. So we need to know more. For example, ketamine, how it works, lidocaine, how it works.
Or maybe methamphetamine or clonidine, which are both
Clonidine, for example. We got some studies with dexmedetomidine, for example, that tells you that you can use it. Of course, there are a lot of limitations. So, and we are knowing better and in more situations that you can use it. But in my own experience, it works. It works. You have to use it in a very simple patients, not very chronic. For example, chronic patients with chronic pain treatment is really useful because you get the baseline of nociception of this patient. So you can treat it over this baseline.
So as another question I had for you before we move on to the other old question is exactly that. So with patients with chronic pain, do you see a difference in the baseline readings in patients using this monitor?
Yeah.
You do?
Definitely. So is one indication, in fact, people with chronic treatment responds to opioids in another way.
And so on the Slido, there's a question here. After using NOL intraoperatively, what analgesia do your patients get postoperatively? Does intraoperative practice actually matter when considering long-term opioid use after surgery? So why don't we start with the first bit?
Yeah, okay, I have to say that this monitor is a very common question. It doesn't predict pain after surgery. Because pain, I've talked all the communication about nociception. Pain is much bigger and complex, isn't it? So there's another centers of the brain working on that. So as you use the bees to treat the propofol and you don't expect, well, we know with the DCA something about delirium after surgery, but it's not a monitor that predicts pain. So there's so many studies that you give the same morphine after surgery with the null and without the null. All of us, I think, nobody here use this monitor, but you keep analgesia after surgery, or in my experience, always 2 milligrams of morphine some people need. And it doesn't mean that. So with the monitor also, you're going to give more analgesia after surgery, but you're going to reduce intraoperatively these objects because you can guide it.
And I guess in the second, it works. So in fact, I'm going to split the second half of this question into 2. So does intraoperative practice actually matter when considering long-term? I'm going to say mid-term. So let's say intraoperative opioid dosing and early recovery into maybe first 24 hours on the ward versus intraoperative into longer-term post-discharge. I wonder if you have any thoughts on that. Maybe Fauzia to start with. No? Or Esteban or Tim?
I don't think we know at the end of the day.
So I think there's some evidence, isn't there, that intraoperative opiate dose is predictive early postoperative because of this wind-up idea. But what about long-term intraoperative usage if we alter intraoperative usage?
As you say, in terms of persistent postoperative opioid use, you see that we looked at this question at that POCI4 in Nashville, and again, there is no data. Most studies do not look at long-term use, so it's another known unknown.
Great. I'm going to ask one last question, which I guess is about overall management pathways. And it will be this question: how can we better avoid patients receiving conflicting information or advice regarding their medications. And they're often seeing many different specialties across lots of clinical areas. So how do we coordinate this? Because this entirely seems to be the truth in my practice. Who coordinates it?
It's tough. It's communication, isn't it? I mean, it's like you need to, as I say, that's one of the advantages of enhanced recovery, I think, is you get everyone to sit in the room, who's involved in looking after the patients, and you come up with a common message and a common pathway that you're going to put together. And we all know that isn't done as well as it should be, but in an ideal way, we all sit together. We all know the pathway we're going to put patients on and the message that we're going to give to patients, and we give a consistent message.
I think it comes down to the patient as well. I mean, it's a problem we've had in our clinic. So we can work really hard with the patient to reduce their opioids, and then they go and see a gastroenterologist, no offense to anyone, but their opioids get put back up again, or they go and see a different GP and something else gets added in. I mean, it's really challenging. But when it comes to the patient, if they can then say, look, I'm working to reduce my opioids, and this is what I want to do, it's about just empowering them so they just have the control over it, because it's their medication at the end of the day.
Yeah. I think that's a core message of this, isn't it? This meeting, collaboration and empowerment. So thank you very much. I'd like to thank all the speakers for 3 very interesting thoughts.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.